dimensions, such as population coverage, service coverage, and financial protection, all under the focus of how strategic purchasing can support the intermediate objective and its final goals. Understanding the needs of the stakeholders in the health system and how to develop an efficient model that prioritizes quality while being cost-effective. This covers the various payment methods, the different actors involved, the population that require the service, the indicated quantities, the benefit design, or the linking payment to information, among other factors. Finally, the topic of digital technologies as a present and future for strategic purchasing and the different policies elements at mitigating the effects of the climate change will also be discussed. Without much more to add, I hope you enjoyed the webinar and Dr. Inke, who is one of the most recognized authorities of the team that bring us together today. Thank you very much, Inke, for accepting the invitation.
Yeah, hi, hello, good morning, and good afternoon, or even good evening. And thank you so much, Mary, for your kind introduction. And above all, thanks so much for having organized this webinar and for inviting me. It's really a great pleasure and an honor to be here with you. And thanks for the interest and for joining here. So we are a relatively small group. Let's see how we organize. In terms of the focus, please keep going and putting into the chat, this information. So my name is Inke Mattauer. I'm a Senior Health Financing Advisor at WHO in Geneva in Switzerland in the Department of Health Financing and Economics. I've been working for many years and am working on health financing policy, conceptually, as well as providing technical support and policy advisory support to countries. I've been leading the global work on strategic purchasing and more recently, over the past few years, have been setting up and leading our work stream on digital technologies for health financing, as well as on the question of how health financing policies can be adapted or can be used for climate mitigation and adaptation measures. Now, I've been asked, now why does it not work? Yep, here we go. I've been asked to talk about for 45 minutes and to give an overview presentation on strategic purchasing, look at the key issues and the aspects that are critical to make purchasing more strategic. And then the idea is that I dive into some more emerging issues, namely on, as I was just mentioning, digital technologies related to purchasing, as well as health financing policies and specifically purchasing policies for climate mitigation and adaptation. And in fact, on those last 2 points, I'm very glad to see my colleague Martin Oranti, who is here participating. Maybe you can put in your camera and wave, although I'm on screen, I'm on sharing mode, so I don't see it, but just so that people see you, because I have been doing a lot of this work with Martin on digital technologies as well as the climate mitigation and adaptation work. So it's great that you're here, Martin. I'm just going to look into a chat for a moment, a few more. Yep, okay. 2 more. So I think we have a mixed group. We have some who are not familiar with strategic purchasing, and then we have others. We have experts here. I've seen you on the list here, like big experts on strategic purchasing. So I guess we have to somehow find a middle ground. And I'm just now going to improvise a little bit. I'll break maybe up more often so that we can also take questions in between. But I would suggest that I try to really spend some good time on the digital technology aspect, as well as the climate mitigation and adaptation questions. So I'm going to rush a little bit through. It's a little bit of running through the initial slides. So it's lots of text, and I won't go through all of them, but I put it this way so that you can always come back afterwards and look at it. As I try to sort of strike a middle ground between, the different backgrounds of colleagues. Okay, let's start. I think most of you have seen this slide. This is just sort of a reminder. This is our WHO framework on UHC. What we want to see is on the right-hand side in green, we want to have the UHC final goals being reached or approached to utilization in line with need, which is often equated as equitable access to health services. We want quality services, and of course, very important, we want universal financial protection. To reach there, we have some UHC intermediate objectives: equity in resource distribution, efficiency, as well as transparency. And on the left-hand side in yellow, we have our core health financing functions: revenue raising, pooling, and purchasing, with benefits design sort of being a fourth function, but adjacent and related to purchasing. So that's just sort of the framework to keep in mind. Now, what is purchasing and what is strategic purchasing? I'm really rushing through because I think most of you actually know this. Purchasing relates to the relationship between the purchaser, that's the agency or the actor that holds the prepaid and the pooled funding, and the health service provider. It's really this allocation process of resources. And in fact, purchasing occurs in all types of health financing systems, even though it might not be necessarily visible. Often people would say, oh, but we don't have health insurance, so really we don't really have a purchasing function. But purchasing is in all types of health financing. It becomes more explicit and maybe more visible when you have a split between the purchaser and the provider. So here we have some examples of purchasing actors. I'm not going to read it out, but you will recognize that a lot of this is also taking place in your country. I would maybe add here to this list, sort of more generally speaking, health coverage schemes, because we do have, for example, PMJ in India, which is not strictly speaking from a national health accounts point of view, a health insurance agency. It's a government program. Or in Cambodia, we have health equity funds. Again, it's a health coverage program, not a health insurance scheme per se, even though it might show features. So as I was saying, the purchasing functions is more visible when it's actually split, because it does provide more possibilities for provider payment. Or I shouldn't say more possibilities, but easier for sure. Just a quick reminder, purchasing is not the same as procurement. Often this is being confused or sort of used interchangeably, especially in French. The wording sometimes puts the two together. They are related, but they're not the same. So procurement is really about procuring, buying goods and supplies, medicines and other supplies, machines, whatever you need in hospitals and at provider level. And procurement and procurement rules are about relating to determining the volume and the types of goods to buy. It's about selecting the vendors, negotiating prices, etc. Whereas purchasing is really about, providing resources to providers for the provision of health services. So that's what we refer to purchasing of health services. Ministry of Health, as I said, national health insurance schemes and others. So what is strategic purchasing? And I think there are two core elements or types of definition that we can sort of easily keep in mind. One is that purchasing links payments to information. The allocation of resources to providers is based on information on provider performance and on the health needs of the population. If we have that information, then we can make purchasing more strategic because we can adjust accordingly. Another, I think, useful definition is to say that it's the evidence-based engagement in this process by defining the service mix, the service volume, and by selecting the provider mix. So how does one purchase? I will come into more detail about that, but just sort of to give us an initial idea, it's through payment methods, through payment rates that create incentives for providers to manage their expenditure, to sort of influence their behavior, to sort of guide on quantity and quality performance metrics. Now, purchasing is a continuum. We have to see this as a path towards more strategic purchasing, and it's a quite bumpy path. That's what I try to indicate there. And also it's a path that never really ends. This arrow sort of continues, because even in countries where you have, relatively good instruments for strategic purchasing, providers will adjust. They will understand the rules of the game, and they will, adjust accordingly. So one constantly has to, as a purchasing agency, as well as the Ministry of Health, as the overall steward, one has to adjust purchasing instruments to make sure that the incentives remain the way that they should be set to get the provider behavior that you want. So on the left-hand side, passive purchasing means that one allocates resources rather based on norms, such as, the number of beds. The number of beds in a hospital would determine how much the hospital gets. It doesn't say anything about how many patients they have, but let's say a number of beds, which often comes along to a certain extent with number of staff. Passive purchasing means that there's little or no selection of providers and you have little or no quality monitoring. And in that sense, the purchaser is a price and quality taker, not actively designing prices or quality metrics. They just sort of accept what actually comes in from the providers. Whereas strategic purchasing, on the other hand, is that payment systems are used to create deliberate incentives for efficiency, equity, and quality. There's selective contracting taking place, and we'll come to talk about this in more detail, what it all means. Above all, the purchaser is a price and quality maker. They are active in determining setting prices and setting rules, provisions in contracts for quality. So maybe just to round this up as my introductory notes, why is strategic purchasing critical for progress towards universal health coverage? And I like this sentence that Joe Cutzin, our former unit head of our health financing team, has, sort of said, and I think it's really a catchy message, and one can easily remember. Countries cannot simply spend their way to UHC. Yes, of course, we need more in many countries, we need more resources for the health sector, for sure, but that in itself is not getting us closer towards UHC. It needs more than just having the resources. So revenue raising and effective pooling or pooling arrangements are important. They're critical. But this potential of available revenues and the potential that the pooling architecture creates becomes only real through purchasing, through strategic purchasing. It's this translation from having the resources available, having them pooled, and then translating that by getting it to the providers in the way that it sends incentives. So in that sense, we can say there won't be progress towards UHC without effective spending, effective funding flows and payment methods. Now let's go into this a little bit deeper. I'm just looking on the watch in between to make sure that I'll stay within my schedule. So let's look into some of the policy instruments for strategic purchasing. And I have lots of text there, and I really don't want to go into all of that. We'll just have to strike the balance here among participants, but I'll just highlight some of the core issues. And so basically here we see an inner circle, which outlines or which sort of summarizes the core areas, core elements, if I may say, of strategic purchasing. The first one is about further specifying the benefits. So there's benefit design as a function, as that which is adjacent, but within purchasing, or as part of our strategic purchasing sort of approach, these benefits have to be further specified. Second, providers have to be selected. It's really about the question from whom to buy. First question is what specifically to buy, which services, which incentives, interventions. And the third core element is the design of the financial or non-financial incentives, or a combination there too. So that's the core of strategic purchasing. And then in the wider circle, we have two other elements, which is one about management of information systems. So as I was saying, information is a core aspect of making purchasing more strategic. We need information, so it needs to be managed. And then last but not least, we also need governance. We need certain accountability mechanisms. We need oversight mechanisms to support purchasing being more strategic. So I'll now go into each of these aspects, but as I say, I'm just highlighting certain aspects. So as I mentioned, decisions on the benefit design is a little bit outside purchasing per se. Often, in fact, the decisions on the benefit design are taken by higher levels of government. Could be even within Parliament sort of, passing a law that states, what's in the package, what's covered. Okay, but nonetheless, the purchasing agency or agencies, they play a critical role in further operationalizing the stated benefits within the given budget and within this list, within this package. So they can, as a purchasing agency or actor, they can, decide what's the focus that we want to put on primary healthcare, in prevention and promotion. How much do we want to focus and shift our attention and the funding to cost-effective services? They can also make choices on specific treatment options for a specific health condition. And I really like the example of Thailand, and I'm giving it since so many years, but just this morning I looked it up again, what's the latest policy. So long ago when Thailand, I think about more than 20 years ago, introduced its universal coverage scheme, a few years later then after that, I think around 2008, they decided that for dialysis patients, they will actually offer peritoneal dialysis. I hope I pronounced that correct. Because this is more cost effective than the actual hemodialysis. And just actually more recently, they have sort of re-emphasized and determined that this is the first policy choice, or this is the first treatment choice, peritoneal dialysis, because it's more cost effective. There are issues, of course, in terms of life. Not sure whether it's about life expectancy, but certainly there are differences between peritoneal and hemodialysis. But still, they say it's more cost effective. This is the starting point. Maybe for some patients, we'll shift elsewhere. But they make a specific choice. So this is just an example to show that the purchasing agency does actually have a certain leverage on that. Or another example here, the purchasing agency can determine and can decide on the medicines to be covered. So while the benefit package that has been passed by a higher level of government, Parliament says, okay, for these types of diseases or this level of care, drugs are covered, the purchasing agency could say, okay, fine, but we only cover, or primarily only cover, generics. So again, it's a choice, it's specifying, it's operationalizing the stated benefits. And then part of specifying benefits is also the specification of conditions of access, which is basically patient cost sharing and the referral rules, the gatekeeping rules. Often this is not sort of seen as part of purchasing or the specification of benefits, but of course this is an important part that has to come along. It has to be also, of course, aligned with the provider payment methods. Let's move on to the next key element, selecting providers. The purchaser or the purchasers need to define and specify the levels. Is this care provided at primary care level only, or is this special service only available at secondary level? So that's about the levels. And also one needs to determine which types of providers are going to be allowed to offer the services. Public only or also private. And this is really a super important and critical decision, because if private providers are being included in offering services, it has massive cost implications. It's already a couple of years ago, but I looked at this for both Morocco and Tunisia. The National Health Insurance Scheme, primarily for the formal sector, in these countries, has included provision of services also through private providers. And in fact, a huge amount now, more than 80%, at least when we looked at this a couple of years ago, it might have changed. I have to update this, but it's not specifically about Tunisia and Morocco. It's just giving you the sense of what can happen. If private providers are being included, it means that, and if there aren't sort of stricter gatekeeping rules or higher cost sharing rules, it means that usage of private providers will go up, and then a large share of the resources from this agency, from the purchaser, would go to private providers. So as I was saying, in Tunisia and Morocco some years ago, it was more than 80% and 20% only going to the public sector, which really meant that the public hospitals and public providers, they were sort of, I'm saying it in quotation mark, but they were kind of losing out. because they didn't get as much money as they were actually, assuming. So apart from this very important question, another one is about selective contracting, as I mentioned already. So will all providers per se upfront be part of the scheme to offer services, or will there be some sort of selection, some specific selective contracting? Just to say, obviously, this is challenging for sure. It's not impossible, but it's challenging for various reasons. First, in rural and remote areas, only one provider may be available. So, selective contracting is practically not really taking place. Plus, maybe more fundamental, even more challenging, is that it's politically difficult to, let's say, exclude certain public providers. How have countries gone around it? They have used accreditation. And so depending on the accreditation score, which sort of gives an idea of the level of quality in terms of structure, but also in terms of process, gives an idea of the quality that the provider offers. And then one can sort of adjust the payment rate. So that's sort of an in-between road. Let's look at the very important aspect of how to pay providers. So the fundamental objective here is to set coherent incentives. Now, this is challenging. There isn't sort of one response overall. We have to ask what's an appropriate payment system, and that very much depends on the health system's objectives, the existing challenges, the type of services to be paid for, the service delivery models that exist, and potentially other contextual factors, such as, what's the existing level of provider autonomy. So hence, from where are we starting? Where do we want to go? Generally speaking, you can say each provider payment method has its advantages and disadvantages. They all create their own financial incentives and disincentives as well. So there isn't one single perfect payment method. Nonetheless, I think we have two core messages, sort of take-home messages. Generally speaking, it's good to move away from line item budgets towards more output-oriented payments. And also, it's certainly advisable to move away from unmanaged fee-for-service. Fee-for-service is that a provider is paid for each service or even specific item in a consultation, and that gives an incentive for providing more and more over provision, right? And if this is unmanaged, this fee-for-service payment, then obviously you will have cost escalation, and the purchaser easily goes above the available budget. So those two messages, I think they're certainly true for the majority of countries. But now, obviously, the question is, what exactly should be this payment system? Payment methods and the rates can be used to influence provider behavior and how these providers then use resources. So again, a general message is that one can pay relatively higher amounts for primary care services to incentivize greater focus on these, right? If you make it financially more attractive to offer these services, then this is what providers are more inclined to. And related thereto, one would then provide relatively lower prices for high cost but low priority services. So when I say relatively higher or relatively lower, what I mean is that obviously there is an average cost for a specific service, but one can just go a little bit above that or a little bit below that, and that will give incentives and signals, financial signals to the provider. I'm not going to go in that, but this is just a table where we have looked at the incentives and disincentives of the different payment methods when they're being applied in a singular way, so as a single payment method, and we looked at the positive and negative impacts on quality of care specifically. Now, as I say, the most important is to set coherent mixed provider payment systems. And this leads us to a trend that we see now since a number of years, if not more even, which is basically to try to have a purposive alignment of different payment methods so as to get a package of incentives that goes in the right direction. So it's an alignment or even a combination of different payment methods. So starting with harmonization of payment methods and rates across different purchasers. That's already a starting point. Or then within a purchaser, one can think of blending different payment methods. So one combines two or more different payment methods. Could be still budget allocations, but add performance-based financing like a performance element, or could be capitation as your base payment, and then you add a performance payment. But there are other combinations also possible. Something else that we see is to move towards bundled pay. So diagnosis-related, DRGs, diagnosis-related groups, or maybe more generally speaking, case payments is one way of bundling. Yeah, because you no longer pay for the consultation, for the medicine, for the whatever, a lab test, for another diagnostic test, but you pay for this whole patient. I want to come to an episode. The word I'm looking is, let's say you have an appendectomy and you spend 3 days in hospital. So it's a payment for this whole service of getting this appendectomy, right? So it's a diagnosis-related group. But, so that's why I'm now shifting to how bundle payment is further evolving. One can also think of an episode that goes beyond just, let's say, a hospital stay for a specific operation. One can also, let's say, include, the next 30 days after the hospital stay, after discharge, and include that within the same payment. Because then, again, that creates different incentives also for the hospitals and for those other providers that come in afterwards for the post-hospital care to look after this patient. Pay for coordination arrangements is another way, not that widespread, I must say, maybe more in a couple of examples from the US, a couple of examples from Europe, as well as from Latin America. But I think pay for coordination yet hasn't really sort of become widespread. But the idea is to pay providers for coordinating across each other in a provider network. What's important is to have a regular revision of payment methods. And of course, one needs complementary administrative mechanisms to ensure that the payments over time continue setting the right incentives. So one needs to have or undertake utilization reviews, some audit, some claims review, as well as fraud control measures. Because as I was saying, providers, they become better and better in understanding of course, they should understand. We don't want providers not to understand, but they will, some and not all, they will become quite good in sort of using the system, and a few may game with the system. So that's why it's important to actually go into that. This is a slide or a graph from the Lancet Commission on financing for PHC. And this specific slide shows a potential pathway towards a blended payment model. And the Lancet Commission has really centered this on a partial capitation model for more strategic purchasing, right? So one can start with simple capitation, but then make it more, I wouldn't say complex, but adjust it further, considering sex or age or other factors that bring down or bring up costs. So you adjust it, and then as a final step, capitation could be blended with another payment method, such as, for example, performance bonus. So this is something that we see now in more and more countries, right? So specifically, the suggestion was, to have other payment methods being combined with, whereas the budget would sort of, serve as covering the unavoidable fixed costs. I'm not going to go further into this for reasons of time. Just another sort of quick reminder, performance-based financing is sometimes equated as strategic purchasing. And let's just be careful on that. Performance-based financing is a payment method. Basically, it's an add-on payment in combination with a base payment, be that budget allocation or capitation. Performance-based financing is often sort of introduced as a scheme, as a program. So obviously it comes with other institutional changes, verification, other support measures with extra funding. In many countries where it has been introduced, it came on top of rigid, very rigid line item budget allocations. And so in that sense, yes, of course, PBF has been a very important entry point and sort of lever to improve purchasing, to make purchasing more strategic. So in that sense, I think it's just important to be clear what's the role of PBF. It should contribute to strategic purchasing, but let's not just equate it. It's one element of strategic purchasing. Okay, I was saying in the beginning that information is one important element, defining element, so to say, for strategic purchasing decisions. So obviously, it's important to have a sound information management system. Again, I'm not going to go into all those aspects here. Maybe just one or 2 points. A strategic direction for a lot of countries is to unify the data collection on patients, on the services delivered across different schemes. Because what we see is that, you have different schemes in a country, very fragmented setup. You have a scheme for formal sector employees or private sector employees. You have another scheme for the civil servants. You have maybe a third theme, which is government funded, but sort of a health insurance type arrangement for people in the informal sector, so not contributing. You still have the Ministry of Health budget, so you have different schemes paying for parts of the services, right? And just starting to unify the data collection will help to move towards harmonization of payment methods, or ultimately, ideally, towards defragmentation and merging maybe some parts of the different schemes into one. So it's about unified data collection, and ultimately also that's the direction to take on unified information management systems, or at least making them interoperable. Now, this brings us a little bit outside purchasing, because this really is sort of an IT issue, but it's so important for us as purchasing policy analysts to keep this in mind. Last but not least, the last element of strategic purchasing, which is on governance arrangements and, making these effective. We can think of governance for purchasing in 2 ways. On the one hand, this is what you see in the yellow circle. That's the large circle. That's the governance across the healthcare purchasing system, right? You have these different purchasing agencies. In a lot of countries, what I have listed here, is sort of a typical setup. You have the Ministry of Health, you have a national health insurance scheme, you still have voluntary health insurance, you have subnational governments, and then maybe even other ministries, education or defense, that also provide health services. So quite fragmented. And so governance of the purchasing system, is across the whole system. And then we also have to think about governance in relation to a specific health purchasing agency, right? And there it's a lot about upward accountability, let's say, towards the government, Ministry of Health, or the ministry in charge of overseeing this agency. Could be Ministry of Labor in some countries for a social health insurance scheme. And very importantly, it's also about accountability towards the beneficiaries, the contributors, the citizens. And so there are a number of tasks or sub-functions, so to say, for those two how can I call it, for those 2 areas of governance, for the system as well as for a specific agency. It's obviously about giving policy and strategic direction. It's about regulation. It's about coordination for the system level. And for the specific agency governance, it's about having effective oversight mechanisms, a board that really meets, not a board on paper, but a board that meets, that is really representative of the different stakeholders across the country, across the people, the beneficiaries. It's about participation. It's about clear accountability lines. It sounds very obvious, very self-evident, but it's not, because when you actually go into some of the regulatory provisions around governance for an agency, you would find multiple accountability lines that cross each other. It's unclear who reports to whom. So that is quite important. And also, I think an area that hasn't really gotten as much as attention in regulation, but also in real practice, it's empowerment of citizens and patients, giving them information on their entitlements and rights. is establishing functional feedback channels or complaints mechanisms. So there's, I think, a lot of work here in this area. Okay, I think I'll talk another 15 minutes, and then if that's okay, then we'll go into discussion. Let's talk about challenges, but very briefly. I think I'm just running through a little bit. How feasible is strategic purchasing? How easy is it? And here my sort of simple take-home message is that, you know, these reforms or these changes in the purchasing arrangements or purchasing instruments, they don't have to be big bang changes. They can be gradual, and they can be in several reform packages. And that's the difference, let's say, to pooling reforms. A pooling reform is more big bang, or it's sort of more difficult to compartmentalize it into several packages. Either you merge or you don't. It's like, you know, it's a bigger change. But for purchasing, it can be relatively incremental. If you start building the information management system, yeah, as I was saying, unifying the information being collected, unifying ideally the information management system as such. A next step is to specify benefits, to align with provider payments, then go into the payment methods directly in terms of optimizing incentives, etc., etc. And a lot of these changes, they are within the realm of the health sector. They can often be steered by the Ministry of Health. There's no need for, you know, parliamentarian, you know, lawmaking. It depends again on the country setup, but a lot is, you know, really at the technical level. But of course, this doesn't mean that it's easy. There is still a political economy behind this, because behind these technical issues, there are group interests. There are the providers with certain interests. There are, you know, potentially certain patient groups that are well organized, you know, wanting to push certain interests for that specific patient group. The purchasing agency will have another interest. Hospitals might again be organized specifically. So the political and the institutional feasibility must be well understood and addressed so as to steer well, you know, these packaged reforms in purchasing. So there are a number of challenges. I don't really want to go into all of them because I want to have enough time for the subject of digital technologies, but, you know, just have a look at them. It's, you know, fairly clear in terms of the core messages. And I'll end this overview of strategic purchasing with these four key messages of how to address the challenges. So first of all, it requires capacity to introduce these changes. So it has to be well prepared, well thought of. There's a whole range of strategic purchasing measures and policy options that exist. It has to really be sequenced, well thought through what comes after what. Second, it's so important to have to set up or to take on a system perspective. Let's not try to optimize a specific scheme only. Of course, one also has to optimize, you know, the schemes, but always with a system perspective, so as to ensure that, you know, we don't make things better for one specific population groups, whereas overall, you know, inequities would arise across different schemes. So that's why the system perspective is important. And that's why unifying information management systems, again, is so important, because only with that information can you take on the system perspective. I spoke already about the sequencing, as I was saying. And last but not least, I'm just reiterating, it's so important to put focus on effective governance arrangements. As I said, I think this subject is sort of getting not enough attention. So I think there's still, you know, lots of potential for further research, understanding these governance arrangements. And of course, in policy, in practice, we need more emphasis on governance. Okay, here I've put on a couple of discussion questions. You know, maybe they're of interest to you or to colleagues or to your team to sort of discuss through what this means for your own country or for, you know, the work that you're doing. Some material, but now let's move on to digital technologies for purchasing. And just to say, Martin Orantier, who is here also among the participants, has been, you know, a colleague with whom I've been working on this together. So what are the digital technologies? They can be referred to as electronic tools, systems, and devices that generate, store, process, or transmit data. It kind of sounds very dry, but if you really think about it, I mean, this is what digital tools really do. It's a lot about generating data, processing, primarily, as well as transmitting. Here are some examples. So apart from, let's say 20 years ago, 30 years ago, we had an Excel file and we had, our stick or diskettes. This is past. Now we have web-based databases and platforms that provide real-time data. And so this, has opened up so many other possibilities, especially in purchasing, but also in the other health financing functions. Then, of course, we have this whole range, this inundation, so to say, of mobile phone applications that help members, let's say, of a health insurance scheme or of a health coverage scheme to get information about benefits, about where to get services. Some mobile phone applications would allow to make your contribution payments via your mobile phone, or you could register, you could enroll, many other functions and features. Quite amazing what's all happening in this area. Then we have digital payments. Now here I'm thinking more of the digital payment systems going to providers, to facilities. This is a real important aspect, especially when it comes to granting more financial autonomy to facilities. Let's say in the past, even having a bank account was already a challenge, let's say, for remote facilities, or getting, access to cash. They had to sort of travel to their bank and then get the payments. The digital payments is opening up a huge world of supporting financial autonomy. Big data analytics, of course, machine learning, artificial intelligence. I will come to talk more about examples in this area. And last but not least, blockchain can be used. Less examples so far, I think, in the field of health financing, but I'll come back to that. So you have seen this slide. It's our framework for health financing. And what does it look like now when we think of digital technologies? This is really where the digital technologies come in. They are at the level of the health financing functions, revenue raising, pooling, purchasing, or even sub-functions. And actually, this picture or this graph should look more messy even than it is, because it can be quite messy. It's not just two, digital tools or digital technologies that are out there. There might be several. So this is an issue. And this is also what the Minister of Health has to get hands on and get an overview. What's all happening in the health financing sector with respect to digital technologies? But ideally, when these digital technologies support and facilitate and enable health financing functions or specific subtasks, then we can assume that they contribute to progress in the UHC intermediate objectives, as well as ultimately towards the UHC final goals. There is obviously an attribution issue, and it's sort of challenging and difficult to show that. And of course, there are many other factors that shift us towards the right, but if well designed and well implemented, then there can be this contribution. So why does this matter? Why should we really think and understand the role of digital technologies? They change how health financing functions and tasks are undertaken. As I was saying, ideally, they support, they simplify, they enable, right? But they also change how the different health financing stakeholders interact. Ministry of Health with purchasing agencies with providers, providers with patients. So these interactions, they change. But despite all those changes, at the end of the day, what we want is, or what should be, is that the core health financing principles, the desirable health financing attributes. I haven't really been talking so much about that, but it's basically a list of desirable attributes that we would like to see happening in health financing, because they give us an indication that we're moving in the right direction. These core health financing principles, they must remain valid. Right? I've just summarized them here in 3 points. There are many more, but these are the 3 core points around each of the or health financing functions. So we want predominant reliance on public funding. We want to maximize redistributive capacity, namely lower out-of-pocket expenditure, improve pooling, and last but not least, we want to shift towards strategic purchasing. So in a positive scenario, digital technology can enhance, simplify, or support a health financing function or a specific task, or it could also help to inform a health financing policy design that is very important, conducive to UHC. So that's what we want to see. However, in practice, and that's what we see happening in countries, is that the use of digital technologies may also play out in a negative way. One, the application of a in principle good digital technology can negatively affect a health financing function or a task because it's inadequately designed or inadequately implemented, or there's a lack of an alignment with the digital ecosystem. So the digital technology doesn't really fit into what's actually out there. You might not have internet connectivity. There might even be power cuts. People may not have the adequate level of digital literacy, so the digital technology simply does not fit, and then it, can become more cumbersome than be of any help. However, we have also other examples where the use of digital technology where the use of a digital technology enhances, simplifies, or supports a health financing mechanism or a function that by itself is not UHC oriented in the first place. And I usually give this one example, and you have to sort of deal with it with caution, but it's just to sort of illustrate what I mean. In a lot of lower and low middle income countries, we see that voluntary health insurance is sort of entering the market and making really use of digital technologies for mobile phone applications and other digital technologies, and it helps them to really enter the market and to make it easier for members to actually enroll to them. So you could say, well, that's great, yes. But the issue is that we also have this digital divide between the public sector and the private sector. So voluntary health insurance sort of being in the private sector. What it could mean, again, would be great to have very specific country evidence. It could mean that, the reliance on public funding gets smaller. The digital technologies in a way help voluntary health insurance to expand. And the question is that what you want in this country? Because if voluntary health insurance expands in a way that is not regulated, not coordinated with the public finance and the public coverage scheme, then obviously it creates issues. So all I'm saying is there are issues, there are risks, and we should not just sort of, follow the hype about digital technologies, but really, think and assess, not think, really assess and then think, what are the risks, what are the challenges? I'll just want to give some examples of the role of digital technologies in health financing. In purchasing, sorry, I'm focusing on purchasing. And the starting point is really to have a digital claims system, digitalize claims, so that providers can submit their claims through an electronic channel or whatever the system is, and the purchasing agency can review and adjudicate quickly within this digital system. That creates cost and time savings for both purchasers and providers. It makes it easier to identify duplicate or flawed claims. It reduces the time to actually get providers paid. So these are efficiency gains because you can bring down your admin cost. You might reduce runners' payments. And so that's on the efficiency side. Then a next step in digital claims management is to have automation and apply machine learning to support the detection of fraudulent cases, and again, at lower cost. And we have a number of country examples. There is an additional effect to that. So if providers actually know that, there's a quite tight control system, an automated control system where, let's say, the claims come back automatically, it might mean, okay, you sort of more quickly, that there are two directions that this could have effects. One is, they just sort of quickly put it in, they will know it comes back automatically. But on the other hand, you could also assume that, the health providers, they grow aware of these more advanced detection techniques. And, as such, the purchasers can actually expect some more diligence in the claims management, in the claims submission. A lot of these controls are sort of more on the, how can I call it, on the formal side of it, have you provided the right information in the right format? But then obviously when it comes to more content related controls, then this diligence becomes important. Mary, I see it's now 3 o'clock. I'm not sure whether I'll be able to go into the climate discussion. I think it would be good to break up at a certain point. I'll just rush through the next couple of slides, and then we'll have a break for questions and for comments. But my main point here is to say that digital claims, they enable and they unlock some more advanced purchasing tasks. So in some countries, such as Estonia, it's really sort of this a country with a very advanced purchasing system. Using digital technologies, one can set service contracts automatically. The contract execution can be monitored automatically. Contract execution meaning how much has the provider already sort of spent on its volume that it has sort of received through the contract. Is it over the volume or the budget that has been given to this provider? Is it still below? And of course, if you have all this digital claims data, then it's much easier to use it, analyze it for health financing quality design and revisions. Just a couple of graphs that's summarizing, all those different sub-functions that can be supported through digital technologies or specifically through machine learning. This is the example here of Estonia. Obviously, we have some broader benefits of digital technologies. They can enable a real-time exchange of data, and they can overcome fundamental challenges that are inherent in paper-based data systems. They can help to enable certain functions or health financing policy options that would otherwise not be possible because it would be too cumbersome. It wouldn't be possible to do it all manually. It can only be, certain functions can only be done on an automated basis. But of course, there are risks, there are challenges. I mentioned already the lack of alignment between design and implementation. The lack of alignment between design and or implementation and the contextual conditions, the digital ecosystem. So it's very important to actually come up with a strategy that brings the two together. So a number of lessons, but I think I stop here. You can have a look at these slides if you're interested. Of course, there is really need to have good governance around these digital technologies for health financing, regulation, capacity strengthening, analysis. First of all, understanding what are the effects of digital technologies, or anticipating what are the effects, what are the benefits, but also what are potential risks. And the more we actually learn about this from specific country examples, the more we can use that information, for one's own country, assessment, planning, design, planning the implementation to avoid certain mistakes, because certain mistakes, they can be anticipated. And so upfront, one can already think about how to go about them. I think we're still in this process of requiring more evidence on how digital technologies affect health financing. I think, fortunately, the community of colleagues working on digital technologies and health financing is growing slowly, but it's growing. We have more and more country practice, but again, I think there's a really big need to get more insights on that subject. So I guess I stop here. Unfortunately, this very important aspect of climate mitigation and adaptation, I don't think I stop here at least. So I will go now outside slide mode sharing, and I will, be very happy to respond to or get your comments, get your views, your reflections or questions.
Thank you, Inke, for interesting presentation. I think that there are some questions in the chat.
Okay. Okay.
Yes, the first one is to Juan from Tadeo University. Thank you for webinar. What would be an appropriate payment system in rural and remote areas that would align with improving access to this population to contribute to universal health coverage in these countries?
Yeah, thank you. That's a great question and very pertinent question, relevant for so many countries. Again, it's difficult to sort of give a blueprint, but as I was saying, I think it's important to first of all understand what are the problems in terms of providing access. Is it a quality issue? Is it an issue in terms of having the drugs available? So first of all, understanding the problem setup, and then also looking at what's the existing payment system and where are the challenges. In a lot of countries, we have very rigid line item budget allocations, and they don't really relate to the actual needs of the population. So is it possible, do the public financial management rules to allow to make those these rigid lines a little bit less rigid? Like, would it be possible to have sort of some shifting, starting with 10 or 20% or whatever, across the different lines, right? So that's one starting point. Or can one introduce, let's say, a performance related element in the payment system? So let's say 80% of the funding going to facilities is through your existing payment system. So in this case, line item budget, a little bit more less rigid than before. And then 20% or whatever, 15% comes in through a performance pay. Or is it possible? It depends also on, what is the information management system like? How digitalized are the facilities? Is it possible to introduce capitation? Capitation meaning a payment per person for a different, for a specific time framework, be it 3 months, be it 6 months, be it a year, for a defined package, which then could be further adjusted by age, by sex, or by other health risk factors. But that requires information. It requires a good information management system. So in that sense, it's difficult to give a generic answer to your question, but I think there are some routes to think about.
Thank you, Inke. I invite all that raise the hand and please interact with Inke.
And by the way, I mean, there are colleagues here in this, or there were, I'm just seeing who, there are colleagues who are also working, very concretely, practically at country level on exactly that question. So, please also come in, share your experience, not now giving a name of who I think could come in, but feel free to come in, give some very concrete experience, lessons, so to say, from the ground on introducing new payment methods.
Yes.
Just raise your hand, come in.
Yes, there are other questions in the chat. Thank you for interesting information. I would like to ask the following: what payment system could be appropriate to ensure effective delivery of outpatient medication and reduce access barriers from patients with chronic disease or multimorbidity?
Yeah, again, such an important point, with NCDs on the rise. In fact, we are starting some work to look into more detail in precisely that question, outpatient medicines, because as we know, they constitute a huge share of overall out-of-pocket expenditure, and of course, they create financial barriers. What are the options? Again, it depends on the information management system, what is already available. But I'm just outlining two areas or some ideas. One is one could think of a specific chronic disease management program. So let's say a number of patients that are registered to a facility are being put on this program. And then you don't pay fee for service for each and every little service that's being provided, but for managing this patient. That's one option. Another one is, as I was already outlining, I mean, we know the limits of rigid line item budgets. It's obviously specifically severe for chronic patients that need a lot of drugs on a regular basis. But of course, it's also challenging for the rest of the population. So again, the question, is it possible? Can we think of moving away from the rigid line item budgets and shift towards some capitation, whereby at least certain medicines, defined package of medicines are already being included. And then let me give the example of Estonia. Now, obviously, this might not be replicable for many countries, but I think this idea is important to be shared. So in Estonia, even though it's a high-income country, in Europe, a very small country, they still have very, very high out-of-pocket expenditure in comparison to the rest of the European Union countries. And but it's a highly digitalized country, so they have lots of information. Everything is digitalized. You get your prescription at the doctor's office, and then you go to the pharmacy. But it's an electronic prescription, so you don't go there with your paper. And they have introduced a system where your expenses on prescribed outpatient medicines are being automatically accumulated, added up. And once you have reached a certain amount, a threshold, then an additional medicines benefit kicks in, right? So then you don't have to pay upfront for the medicines that you get. And then in previous, before this reform, you had then to apply to get reimbursed. You didn't know whether you get reimbursed. You didn't know, whether you were eligible. Had you already reached the threshold? It was very cumbersome, also from an administrative point of view, for the patient as well as for the health insurance fund. And so lots of people actually did not benefit from this additional medicines benefit. And so for me, this is a fantastic example of how real-time data and automation can be used to actually exempt or reduce the out-of-pocket expenditure.
Okay.
We have some other questions. And again, I'm really encouraging other colleagues to come in and share, their experience or respond to some of these questions. Because we have some experts here, many experts.
Yes.
Louise has raised her hand. Want to come in?
I
Yes,
can. Are you able to hear me?
Yes.
Great. Hi. Thank you so much for putting this together. It's really a fantastic resource. I work quite a lot in LMICs, and what I'm finding quite devastating is by the time we talk about strategic purchasing, the politicians have got hold of the benefit package, right? And they've promised, a substantive benefit package to the whole population. I don't think anybody ever priced it. Then it goes out. I think possibly in many instances it's fee for service because it seems to be the way to pay. The net result is that, the providers some of the providers will game the system. There's an influx of costs and volumes, both in terms of the cost of the claim as well as the volumes for processing. And it all sort of gets very stuck. So by the time you start talking about strategic purchasing, you're almost already on the back foot. The population has lost a bit of faith in this new scheme. And now you're trying to sort of, make small adjustments in what is quite a complex landscape. That was my one comment. My other is that I'm from South Africa. And I've spent the first half of my career in private health, in insurance, and the second half in public. And if I look at the information technology systems in the private sector in South Africa, they are world-class. The ability, because they have to manage risk, right? They have to know who's paying for that GP consultation or that hospital event. So the ability, not just for pure claims processing, but also for clinical and financial audit is just astounding. Now we have that alongside a health reform agenda where we're trying to implement NHI. And the government's now trying to build this capacity from scratch, which has taken probably, 25 years to build. So yeah, my second thought is around the private sector and the importance of managing the governance around the private sector in these arrangements from the outset, that it doesn't affect the health system down the line. It's quite difficult to go back from. Thank you.
Yeah, fantastic. Thank you. Thank you so much for these two comments and reflections. And I couldn't agree more. Yeah. So what you refer to in your first comment is really the benefit design, which is, as I say, adjacent to purchasing. So that's why I haven't really gone so much into it. But as you say, it has to be costed. There has to be a consultation process with different stakeholders, but also with of course, with representatives from the population. Well, what should be in the benefit package? Because it can't be all. It's not affordable for many countries to have everything in there. So what is it that we start with? And for which population groups? Is it universal? Is it for specific population groups that are, particularly vulnerable, or is it, do we think about exemption of some small cost sharing, which again, unfortunately, is a reality in so many countries? And so this process is super important. It hasn't really been so much part here now of this. I haven't really focused so much on cost sharing and all the options, but I fully agree. But one thing I think we really have to one key message is, don't start with fee for service. As countries are setting up these schemes, health insurance schemes, national health insurance schemes, or health coverage schemes, let's not use fee for service. Or if you use fee for service, then have a very strict expenditure ceiling. Have a clear budget ceiling or volume ceiling so that it's still staying within the budget. So yeah, but in fact, we are going to have another we're thinking about, a discussion, set up a discussion of why do countries prefer to start with fee for service, because we see it again and again. Why is this happening? Whereas, this is one of the payment methods that's really harmful for, creating your universal, health coverage scheme. And on your second point, really, I also fully agree, and please others also come in. But you refer to this digital divide. Again, we have this digital divide, not just between women and men, and between, better off population groups and poorer population groups, or rural versus and rich countries versus poorer countries. We also have it between the sectors, between the public and the private sector. And yes, the private sector is so much ahead. I was just at the Prince Mahidol Award Conference in Bangkok 10 days ago, which was on digital health, and it was also discussing this issue, or I was discussing this issue. Is it possible for the public sector to actually catch up to reduce this digital divide? It's very difficult. It starts with having complete different salary structures between these different sectors. And so, yeah, that's a real issue. But this doesn't mean that the public sector cannot do anything about it. There's regulation of private sector provision. So provision is one side, one element of it, but also regulation of voluntary health insurance. So this is extremely important, let's say in South Africa, about the question what's their future role, or where are they? So there are possibilities, and regulation is not just a stick. I mean, it's about enabling, it's about alignment. It's a constant process, because as the benefit package hopefully increases in the public sector, it needs to be adjusted in the private sector, in the voluntary health insurance market, so that the two complement each other rather than compete. But yeah, I mean, these points are great. Thank you. Okay, just looking, do we have other questions? There's a question on Colombia. There was one before. Let's go up.
Juan Virdis.
Yeah.
Yeah. Thank you for the interesting presentation. I'd like to ask if you are aware of any general guidelines or can suggest literature on optimal pool size in resource allocation, example, risk adjustment capitation allocation, from a strategic purchasing perspective. This is one.
Yeah. Okay. If I understand the question well, I'm not 100% sure. I think there's several elements in there, right? One is the pool size, so the number of people within a pool, within a scheme. Is there an optimal pool size? Well, let's put it this way. Ideally, as large as possible. Ideally, as little fragmented as possible. That's on the pool size, if I understand the question correctly. Now, the other element is the risk-adjusted capitation allocation. How to go about it? How to introduce those risk-adjusted elements? I think, I hope I understand you well, but please, otherwise, Juan, please come in and clarify what you're referring to. This can be gradual. So one can set up the capitation system at the starting point, which is one payment amount per person from the start. And then over time, as the system is being set up, let's say over, the next 2 years, then introduce some of these risk adjustment factors. As I say, 6 and 8 are sort of the initial ones. And as more information is available in the data system, then it will be easier to also adjust for other factors. I'm not sure whether this is what your question is about. I have actually one question, and maybe some colleagues want to respond there. The Lancet Commission also suggests to have this gradual path. So to start with capitation and then slowly sort of adjust, introduce these risk factors and then have blending. But is there an opportunity for some leapfrogging? I mean, would it be possible to start already with some adjustment right from the start? It's a question I don't have an answer. I think it's very country specific what's feasible, but yeah, I'm just, showing or just, opening the questions that I have myself. Juan, was this the question? Did we respond to your question?
Hi, Inke. Oh, that was my question. Yeah, my question was about, I know that the larger the pool size, the better. But also there is some literature warning about pool sizes that are too large, and because the authorities lose managerial capacity. So I was asking if you are aware of some optimal pool size in terms of there is some middle point between the largest you can get and only one person.
Yeah. So personally, I'm not aware of any specific literature that says, okay, this is the optimal pool size. But, again, it depends very much on the country. In very large countries, we have a federal setup, take India, take Nigeria. There, the pool often is at state level anyway. So, you sort of break up already this huge population size. Indonesia, on the other hand, has, 60 or so million or 270 million people, and it's all in one pool. Is it too large? I don't think so. It's also a question of, the important thing is that the pooling architecture, this potential that this pooling architecture creates is being adequately translated into your purchasing arrangements. Right. And again, in Indonesia as well, you have provinces, and below provinces, you have again, units. And so in that sense, there is again some fragmentation that's taking place through the purchasing structure. And so these two aspects, they need to be well aligned. I mean, in the end, the pooling architecture only creates the potential. And if it's not used adequately for your purchasing arrangements, then you lose out on a great pooling architecture that you have set up. But if it's not translated adequately in your purchasing, then yeah, you're losing.
Yeah, thank you.
We have Martin, please come in.
Yes, good afternoon, Inke. You mentioned my name already. Good afternoon, everyone. I wanted to come in on the point indeed of the Lancet model of 2022 and how to get to blended payment, or maybe some blending of capitation and performance-based payments. And I also have, I think, the same question that you posed, Inke. Will it always go in this order, that you start with capitation, simple capitation, then you move to risk-based capitation or risk-adjusted capitation, and then you introduce performance elements? I think in practice in countries, what we see that it will not always go, so it's not such a dry process where you really take all the steps one by one, and we will see these forms of leapfrogging. And this also goes back a bit to the question, I think one of the first questions about what is a proper model, an appropriate model for really rural, remote areas. And I think it will often not start with, okay, we will just do simple capitation, because one of the things that is often lacking is just population data, or the kind of data that you would even need to start a capitation is so unreliable that you'll probably find another entry point. And even fee for service, I think, from my experience, although I fully agree with what you say, it can easily lead to over provision in some of the really remote areas, rural areas. Sometimes, just a form of fee for service, the utilization is often so low that fee for service can be a starting point. But then it would have to be, I would say, you would have to be very selective in which services you would like to pay for. You would still already have to be strategic from the start, like, this is the kind of services that we want to purchase in that specific area. We won't be paying for everything for all services. Yeah, but I also agree. Although the Lancet model is attractive in the way that it was presented, really starting with a very simple capitation, it will not be a solution for all settings. That's also my feeling.
Yeah, great. Thanks a lot, Martin. I mean, you have hands-on, very concrete experience from country work, and so yeah, I appreciate that insight. Yeah, and I suggest we continue this discussion, what it actually really means. Can I just come back on your first point about fee for service? So fee for service can be useful for certain services that you want to prioritize and where you really want the providers to focus on. In that sense, what we refer to as performance-based financing. I mean, in a way, that's a fee for service. You pay a specific fee for each vaccination or for each maternal whatever care visit. In that sense, it's a fee for service, but it's only for very specific selected services where you want higher utilization, where you want to increase provision, right? So fee for service, we cannot just say don't do it at all, but if you apply it, then use it very strategically, right? Okay, then Colombia. There are questions on Colombia.
Yes,
I think
it's for Fabian.
Yep.
Yes, we
Okay.
have observed a shift in the purchasing for pharmaceutical resources, impacting payment patterns and leading to financial issues at dispensing point. This has resulted in increased out-of-pocket spending for those who can afford it.
Yeah.
Of adherence to those. Yes, you can. From your
Thank you so much, Fabian, for this question. I think you refer to the latest reforms, developments, changes taking place in Colombia, right? I have been very familiar with the previous setup in Colombia. I admit that I'm not fully 100% up to date with the latest changes and what effects it has. But so from a very generic point of view, what I see is in the previous system, there were certain elements that were really supporting a move towards strategic purchasing, right? There was, purchase of provider split. We had subsidization for all the people working in the informal economy, which is not about purchasing, it's about pooling and revenue raising, but a lot of elements, going in the right direction. But of course, the system still had its challenges. Now, some of these elements and of these arrangements are being changed or put away. But I don't know what the actual purchasing arrangement looks like right now. So maybe this is really a question for Mary and for other colleagues who are from Colombia to respond. I don't think I'm the right person here. So Mary, over to you, please, if you want.
Okay. Yes, but we need to close. this is the time. Then thank you very much, Inke, for the presentation and discussion. It was very interesting, I think, for everyone. And thank you to everyone too for your participation in this webinar. And the recording is in the webpage of the IHEA and YouTube IHEA page. Thank you very much for everyone.
Thank you from my
Big thanks from my side as well. Thank you for your great questions. It's always very insightful for me also to, you know, get new issues on the table. Thank you so much.